Welcome, everyone, and thank you for joining us. My name is Molly Felton, and I'm the Online Education Specialist here at APIC. The Association for Professionals in Infection Control and Epidemiology is pleased to present this webinar as a partnership with the American Nurses Association. Our session is titled ANA and APIC Webinar, Improving the Clinical Care and Treatment of Patients with Monkeypox Virus. Before we get started, I would like to go over a few items for our participants. Please note that this presentation is being recorded. APIC is in the process of transitioning to a new learning management system in the next week or so. You will be able to access your OneCNE/IPU for this webinar from your new Elevate dashboard at that point. Thank you for your patience as we make this exciting transition. We encourage you to submit your questions at any time during the presentation using the Q&A tab at the bottom of your screen. If you need technical assistance, please send us a message in the chat box or send an email to elearning@apic.org. And now it is my pleasure to introduce our speakers for today's webinar. Anna Liebeck is the APRN Education Program Specialist at the American Nurses Association. She supports the ANA enterprise in addressing the educational needs of advanced practice registered nurses through creation of continuing nursing professional development content. And then we also have Barbara Smith. She is a nurse epidemiologist at the Mount Sinai Health System at the St. Luke's and West campuses in New York City. She is the infection prevention consultant for several independent ambulatory practices, including endoscopy and dialysis centers in the metropolitan region. Barbara, welcome to the program.
Thank you, Molly, and I love that introduction. I'm pleased to introduce our speaker for today, Amanda Carey, who is a nurse practitioner and a manager at the Sexual Health and Wellness Department of the Waltman Walker Health Center in Washington, D.C. area. They're a community-based organization that focuses on expertise in LGBTQ care and HIV care. In addition to having her nurse practitioner degree, Amanda also has a master's in public health from Johns Hopkins University, and she has HIV specialty credentialing from the American Academy of HIV Medicine. She was instrumental in managing and introducing the care for the patients coming to her practice with monkeypox during this most recent outbreak. And it's with great pleasure that we're having her present her expertise today on how she's managed these patients with monkeypox, as well as providing safe care to the staff members as well. Thank you so much, Amanda, and we're looking forward to your presentation.
All right, well, thank you so much for having me. It's an honor to be here. This is a really important group of people and a really timely subject. So I guess we can progress to the objectives page on the PowerPoint, and I'll go through those. So our objectives, we have three main objectives. One is to identify the clinical history and physical assessment components for the monkeypox virus. We also want to describe the infection prevention and control measures for healthcare settings and discuss strategies to improve care and reduce stigma among special populations. So next slide. Let's start with the basics. What is monkeypox? Monkeypox is an orthopox virus. It is in the same family as smallpox, but much less severe. It was first discovered in 1958 among monkeys used for research, but the first human case was in 1970. And so since the 70s, it's been endemic in some areas on the African continent. There are two main clades of monkeypox virus. There's clade 1 that's endemic in Central African countries, the Congo Basin in particular. And then there's clade 2 that's been endemic in Western African countries. Clade 2 is has less mortality associated with it and is generally considered more mild. And it's clade 2 that this current 2022 outbreak has emerged from. So we could go to the next slide. So what's new in 2022 is that areas outside of those endemic areas have been experiencing this outbreak. I'll focus in specifically on the US. Here is a map from the CDC showing the geographic density of cases. At last count, I think as of today, at least there are 28,657 cases. That's up from a couple days ago when this screenshot was captured. And you can really see where the majority of cases are. The darker the color, the more cases there are. And another thing that's particular about this 2022 outbreak is that the data is suggesting that gay, bisexual, and other men who have sex with men make up the majority of the cases that you see here for the current outbreak. You can go to the next slide. So I'd like to first discuss transmission. And just overall, what I'll probably keep repeating is that most of the transmission is coming from direct skin-to-skin contact. So contact with body fluids or lesions, and this is sustained physical contact with a person with monkeypox. And so it is not a casual brushing by someone. I like to think of it as contact with a little friction there. Other ways that we think it's transmitted is exposure to respiratory secretions during prolonged face-to-face contact. And so again, this isn't airborne. We're not even talking small droplets. We're talking intimate contact with large respiratory secretions. Touching bedding, clothing, towels can also be a source of transmission if they've been used by someone with monkeypox. Particular in terms when it comes to fomites, we're particularly concerned about porous surfaces as opposed to hard surfaces. So that cloth is really where it can kind of stick in and hide. The one thing to note is that when I'm talking about skin-to-skin contact during this 2022 outbreak, we've noticed that the particular skin-to-skin contact has mostly been sexual contact, which is pretty efficient. So this includes sex, including oral, anal sex, vaginal sex, although much less so, and skin-to-skin touching of the genitals when someone has monkeypox. It's in terms of healthcare associated transmission, we're talking, I think there may have been 3 total cases, and we'll get into that next, but they've mostly been associated with needle sticks during the collection of samples for testing. In terms of monkeypox in endemic countries, there has been animal to human contact quite a bit. We think the main vector are rodents, but we have not seen that in the US with this outbreak that we're dealing with now. We know that a mother can pass it to a child in utero or during birth as well, but we haven't seen that with this 2022 outbreak. So just to sum up, this is not casual contact. This is sustained physical contact, skin to skin or intimate face-to-face contact that is spreading the outbreak as we know it now. So we can go to the next slide and we'll, oh, I think I gave something away. I apologize, but let's go through the poll. Which of these are actual reported cases of transmission of monkeypox in the US during this current outbreak? So transmission among men during sexual contact with other men, heterosexual sexual contact, excuse me, needle stick with involving a skin lesion, contaminated sharp, transmission to a child from a caregiver via non-sexual skin-to-skin contact, or direct contact with an infected animal. I'll let folks have some time to answer those questions. All right, so folks have put in their answers and it looks pretty good. As I gave away, there hasn't been transmission among animal to human with this current outbreak. There has, and the majority of cases have been among men during sexual contact with other men. There has been a case of heterosexual sexual contact, and there's been 3 cases of needle transmission during needle stick from a contaminated sharp. And specifically when it comes to that contaminated sharp, it's during the unroofing of lesions for the purposes of collecting a sample. And as we'll talk about, that has changed some guidelines. So yes, this is the current slide. So our knowledge is currently evolving, but based on the poll that we just saw, we can kind of see where the majority of transmission is occurring. So the CDC does recommend that any patient, regardless of sexual or gender identity, presenting with a rash consistent with monkeypox be considered for testing. You can, yeah, you can go on to the next slide. Let's see here. So let's talk about the history and physical exam, and I'll get ahead of myself just a little bit to note that when you're doing a history and physical exam with someone that you're concerned about monkeypox, you're going to want to make sure that you're wearing the CDC PPE that's listed that we'll review, and that the patient is wearing a mask and covering any lesions that aren't being examined. And so to go through the history and physical, I like to go through it as a timeline. So I want to ask what symptoms they're having when, and document the sequential order of things. So I'm going to want to know, has the patient had fever, chills, headache, flu-like symptoms, fatigue, or swollen lymph nodes? I'll emphasize here that fatigue and swollen lymph nodes have stood out as some major symptoms for monkeypox amongst my patients. You're going to want to know the timing of the rash or any raised bumps on the body, and what that progression looked like and what it felt like. You're also going to want to know if they've had any known exposure, or suspect that they've had a known exposure. And here it's helpful to know a little bit about your local epidemiology. For example, I live and work in Washington, D.C. at a sexual health clinic. And so in D.C., we had quite a high incidence of monkeypox. At one point, the highest rate of new cases in the country per capita. And so by default, most of the patients who come see me, this is on my differential, but you're going to want to be able to talk about social and sexual health history to get that data with your patients as well. We like to normalize talking about a sexual health history. And so I think that could be an entire other presentation on what goes into a good sexual health history, but some ideas specifically related to monkeypox are that you're going to basically want to know, has there been sex with multiple partners in party or event spaces, group sex, bathhouses. These are areas that we've seen a high rate of transmission. And so once you've done your full sexual health history, you'll have a better sense of if your patient is at risk. You can go to the next slide. And I should say before we get to the slide, that's fine, is that when you're going through your history and physical exam, if all signs are pointing to monkeypox, you also want to get a good picture of what their baseline health is. If they're severely immunocompromised for any reason, but specifically we've seen related to HIV, they are at risk for a more serious disease progress. Similarly, if someone has eczema or psoriasis or any kind of inflammatory skin condition, they might be at risk for more severe disease. What is also helpful to know now that the vaccine has been rolled out more and more is whether they've been vaccinated with the smallpox vaccine or, the smallpox and monkeypox vaccine. That can be helpful to know. So on this current slide, I wanted to go over the clinical manifestations. So the chart that you see here, this has been historically how we've thought of monkeypox. So we've thought of it as, before 2022 going in a specific order, which is the incubation period, which is the time from exposure to when symptoms are present, and the patient usually feels fine. That's 3 to 17 days on average. And then we thought of a prodromal period with early signs and symptoms, often flu-like symptoms, for a couple days. And then we see the rash stage, which is when the skin lesions emerge and develop. And then, of course, the recovery stage is when all scabs have fallen off and a fresh layer of new skin has formed. So this can typically last between 2 and 4 weeks. And I think that's still true, but what we've learned is that the flu-like symptoms can come either before or after the rash or not at all. So we've been seeing the progression of disease be a little bit different in this 2022 outbreak. But one thing to note is that the patients are considered contagious until after all the scabs on the skin have fallen off and new skin has grown underneath. And another note on contagiousness, before last week, we were pretty sure that there was no transmission during that pre-symptomatic incubation period. There's been some emerging evidence that has pointed to some pre-symptomatic exposure. I don't think we're ready for prime time yet in terms of quantifying that risk, but maybe we can get to that a little later in the Q&A section. So next slide. This slide is getting a little deeper into the prodromal symptoms, which we now can know can happen before or after the rash. Fever, chills, fatigue, headache, sore throat, cough, swollen glands. Again, what stood out to me seeing patients is the degree to lymphadenopathy and painful lymphadenopathy, as well as a fairly significant fatigue that folks have been talking about. And I guess we can't mention flu-like symptoms in November without mentioning, if you see this without a rash, still think about testing for flu, still think about testing for COVID. You can go on to the next slide. And so this slide reviews, what the CDC has found to be the most reported signs and symptoms. So of course that rash is number one. It's a pretty telltale sign, as well as those flu-like symptoms, fever, fatigue, chills, and so on and so forth. Can go on to the next slide. So here is a slide that delves a little deeper into the clinical manifestations of the lesions in particular. So going from left to right, you'll see, they can start as macules, then become more papular, vesicular, and pustular. I will say, in some of the earlier stages, these can be confused with a lot of other things, like pimples or other STIs like syphilis or herpes. I've actually had several patients come in and say, oh, they don't have any new rashes or lesions, they just have a couple ingrown hairs, and those ingrown hairs had turned out to be, in fact, monkeypox. And so after that pustular phase, eventually the lesions do scab over and come off, and then the rash resolves. These lesions can result in scarring. The bigger the lesion, the the more likely it is to scar, which can be distressing to patients. And sometimes these lesions can start out subtly in places where you might not notice them, including in the oral mucosa or rectal mucosa. And so, but that is considered a contagious and contagious phase of the illness. The rash in this current, like the lesions in the current 2022 outbreak have been very noticeable in the genital or perianal areas because a lot of the skin-to-skin transmission has occurred during sex. Lesions can be very painful, most commonly when they're in the anogenital region. They can be quite painful. They can also be really itchy. They can occur anywhere on the body. So even, they might start in the genital area, but then, I've seen patients with lesions across their chest and arms and back, on hands, and on faces. So the lesions really can be anywhere. And traditionally, before this outbreak, we thought of monkeypox as all being in those lesions, all being in the same stages. But here we see that the lesions can be in different stages and different parts of the body. And I will say, the most painful area that I've seen the lesions is the perianal or internal rectal lesions. And those can be really excruciating, like patients going to the emergency room for pain relief level of excruciating. And I've talked to patients who have actually said even the opioids they got in the ER didn't fix the pain. So pain, it can be a really big part of the clinical manifestations. So you can go to the next slide and we'll start to see some pictures here of different stages of the lesions. I'll say the lesions are, descriptively pretty firm and rubbery, well circumscribed, pretty deep seated. And, after that initial papule and pustule, you'll see a deep umbilication. I think the third lesion from the top left is a pretty classic. You can see that it's papular with that deep umbilication there. But you'll also see these other lesions that look like they have pus in them, some that have scabbed over. And so I think these are some great pictures. We have more pictures coming. And I think, yeah, we can go on to the next slide. So these are some pictures of oral and perioral lesions in patients with monkeypox. I think the pictures labeled A and B are, the kind of distinct lesions that I saw over and over again that I could pretty much diagnosed with monkeypox from across the room looking at them. Those are pretty classic looking. And you'll see, and you can see particularly the one on the nose, how that could be confused with syphilis chancre, for example, like if that were on the penis. There's the difference is I think the monkeypox lesions are a little bit more raised and papular, and the base is more umbilicated, whereas a syphilis chancre has a more flat red base and has some raised edges, but not quite in this papular presentation. You can go on to the next slide. I think this is perianal, anal, and rectal lesions. The lesion labeled F, kind of in the bottom middle, is also a pretty classic lesion that I saw over and over again, that I could pretty well diagnose just by looking at it. And you can see here again that it has a more narrow umbilication than a syphilis chancre, which would have a more wider red base there. The syphilis chancre is also typically not tender, whereas I would guess, since that's so close to the anal verge, that one is probably pretty tender. Another thing to point out here is the picture in G. This is also this is a picture of perianal lesions that are almost confluent and almost look like they could be confused with like a condyloma. I've actually seen this presentation, actually a little worse version of this presentation in a patient living with HIV with a very, very low CD4 count, and had such confluence of lesions that when I first looked at it, it really did look like a condyloma, like warts. And it was only looking closer at the umbilications that I could see that they were monkeypox lesions, basically. You can go on to the next slide. So ocular monkeypox can happen most commonly if, someone's immunosuppressed from HIV, for example, and this can be a severe manifestation. We're going to talk about treatment in a moment, but this is somebody that you would definitely want to talk about treating because it can be vision threatening, and you want to reduce as much harm as you can from monkeypox virus. I fortunately have not seen this among my patients personally, but I have heard of these cases. You can go on to the next slide. So to summarize these these pictures of lesions, here is something from the ShareNet clinical group in Massachusetts that it puts the timeline of the lesions so that you can see the progression. You'll note that at day -4 was the actual exposure, and they're counting day 0 as the first lesion. They did, diagnose the first lesion as initially as a syphilis chancre and gave the IM penicillin as treatment. And then at day 4 to 6, the patient started feeling more unwell, and by day 11, they confirmed it as monkeypox. They, by day 21, the facial lesion was negative, but the genital lesions were still PCR positive. And then by day 28, that's 4 weeks out, the last of the lesions was PCR negative. And I think this is probably as good a place as any to point out that when we're testing for monkeypox virus, you're going to want to swab the lesion, and you need to give it enough pressure to pick up the specimen. But you don't want to unroof the lesions. I think some of the only healthcare setting acquired transmission, I think, has happened in the course of unroofing the lesions with a sharp. We don't have to do that to get a good specimen. I personally have swabbed many specimens that looked dry to me and was still able to come back with a positive DNA orthopox result. And of course, if you're in a room doing this testing, you want to be wearing the appropriate PPE, and you want to make sure your patient is also wearing a mask. So there's lots of things on the differential diagnosis for monkeypox. I mentioned syphilis and herpes because, we've been seeing a lot of these cases present in a sexual health clinic settings because they mimic some of these other conditions, and they're also, we're finding transmitting in with similar behaviors. So I have also seen co-occurring syphilis and co-occurring chlamydia, gonorrhea. So it's important to note that it doesn't exist in a vacuum, and the same way you can get Mpox, there are other infections to think about. So syphilis, herpes, I'll say molluscum contagiosum this can look like a bigger version than molluscum. I'll say molluscum is actually a pox virus, but it is not an orthopox virus. So very different, but it might remind you of that, especially with the little umbilication there. So I included some other things on the differential to think about. Chickenpox. Chickenpox is not a pox virus, but that's something, that sometimes these lesions can be confused with. And ingrown hairs, again, I find patients, and those of you in clinical care probably have found the same thing, that patients have all different ways of describing lesions. They don't tell you I have a lesion. Their descriptions and even their answers to yes or no questions can vary. So sometimes people will just kind of think of an ingrown hair as a different category, but it's important to check that out. Vaccinia virus, this is what you can get from the smallpox vaccine, which is not the variola virus, which is smallpox. So different from smallpox, but can have a similar presentation. And of course, the rectal pain can also have co-occurring chlamydia or gonorrhea, or could just be chlamydia and gonorrhea. So you'll see in red there, I included that when sexual transmission is suspected, it's really important to test for other STIs like chlamydia, gonorrhea, syphilis, HIV, and herpes as well. I made a note there for chlamydia and gonorrhea that three-site testing is important. And what I mean by that is not just taking a urine sample for a genital specimen, but you also, if someone is using their butt for sex or their mouth for sex, you want to take that rectal sample and that throat sample, because both of these infections can be in one place and not the other. So you won't know until you test. So yeah, moving on to treatment. So this is a self-limiting disease. Monkeypox will go away without treatment. And in many cases, supportive care and pain control is enough, being able to give them a timeline and isolation guidelines and supportive care. However, there are some patients that you definitely want to consider treatment for, because this can be extremely painful, and this can also be a scarring disease, and scarring on faces and other areas can be quite harmful to patients kind of recovering from this emotionally and also in society. So you want to think about treatment in severe disease that includes mucous membranes. So of course, the eyes that we talked about, as well as the throat, genitals, anus, these are areas that can have extreme pain, swelling, secondary bacterial infections and abscesses, and of course, scarring. We had a patient here in DC that had some lesions very close to his meatus, and we actually had to send him to a urologist because we were worried about obstructing urine flow. And so we got to think about those sensitive areas and prioritize treatment for those patients. And of course, thinking about treatment for patients who are at high risk for severe disease because of an immunocompromised state. I think most of the really severe cases with monkeypox in this current outbreak have been among people with poorly controlled HIV. I should say, if HIV is well controlled and the patient is on a good antiretroviral regimen, that's not the case. We're really talking about undertreated or not treated patients with HIV. When we think about monkeypox treatment, we also want to think about pediatric populations, those who are pregnant or breastfeeding, and again, those who have other inflammatory skin conditions that might put them at risk for a more severe presentation. You can go on to the next slide. So what am I even talking about? Treatment. There's a couple different options out there, but for all intents and purposes for the 2022 outbreak, we're talking about tecovirimat. The shorthand is TPOXX, and this is a treatment that was FDA approved for smallpox, but not yet FDA approved for monkeypox, although the CDC has issued an expanded access new investigational drug protocol, so that it can be used really as the primary way that we're treating monkeypox specifically. The other cidofovir, I think the risk benefit to that one is not as is not as good as the TPOXX, and the vaccinia immune globulin has also has more limited data. And so you see a little picture there. Most of the time TPOXX is given orally. So that's a picture of a bottle direct from the National Strategic Stockpile that we get by working with our local Department of Health through the CDC. For most, it's weight-based, but for most people, it's going to be 600 milligrams of the tecovirimat twice a day with food. And they come in 250 milligram capsules. So this is 3 capsules twice a day, and the patient needs to take a significant meal with it, ideally 25 grams of fat each time. So it is oral, but it's, there are 3 pretty big pills, and you need to take that for 2 weeks total. TPOXX can be available as in the form of IV, particularly for hospitalized patients. So that is also something to keep in mind if someone is so sick that they can't tolerate the oral. The main way, the way that we're getting TPOXX is through our local Department of Health, and usually the local Department of Health is coordinating with the CDC. So we'll make sure you have links to the CDC monkeypox site, and there's also a number here for urgent after-hour requests for TPOXX. Depending on the city, like DC has made it quite simplified to get TPOXX. In fact, at my clinic, we were very easily able to get a stockpile, so that we could just literally grab it from our stockpile and give to patients. But in short, just work with your local health department on accessing that. And we'll provide some more resources and links to do so. Moving on to, okay, so you have a patient with monkeypox. What do you tell them? It's important for them to isolate. Remember, this is infection that is mostly skin to skin spread, and spread through very close respiratory secretions. So our isolation guidelines, we want to make sure that that doesn't happen. So if you're living alone, it's a little simpler, which is just isolate at home and don't come into contact with others. But of course, if you're living with others in the household, it's important to avoid any close contact with other humans or pets, to wear a well-fitting mask and cover all lesions, and make sure that you're not sharing bedding, linen, towels, any kind of cloth in particular, or anything that could be a fomite. And you're going to want to avoid using contact lenses because of the slide I just showed you about ocular monkeypox. And ideally you're using a different bathroom, but if not, just be cognizant of wiping it down. And ideally you're doing this until lesions have healed. In fact, the initial isolation guidelines were like, don't leave isolation until all lesions have healed with new skin underneath. But as I've said, this can take 2 to 4 weeks. And so that is not practical for people who, can't work from home, don't have any sick benefits from work. People need to move and survive out there. So we just tell them, make sure if you have to leave your house, wear that well-fitting mask, avoid public transportation or areas with a lot of common touch points, and cover those lesions. And you can go on to the next. So partners of patients or others who know they were exposed to monkeypox are going to want to account for that long incubation period up to 21 days and look out for any new rash or flu-like symptoms. And if they do notice a rash, definitely get to their provider as soon as possible and see if we can rule monkeypox out. Obviously, if we rule monkeypox in, we refer to the previous guidelines that we just talked about. And if other symptoms come, without a rash, you're going to want to isolate for 5 days if you have a high suspicion of monkeypox, and again, report to a provider for care and follow-up. We can move on to vaccines. So the vaccines that we're talking about are mainly made for smallpox. I mean, we've eradicated smallpox, but in anticipation of possible bioterrorism acts, we've been developing these vaccines. And because monkeypox is in the same orthopox family as smallpox, we see cross-effectiveness. So there's the ACAM 2000 and the Jynneos vaccine. We're not really going to be talking about the ACAM 2000 very much. This was approved for immunization against smallpox, and it's made available through an emergency access waiver. However, the ACAM 2000 is pretty much the old initial smallpox vaccine that was replication competent. It's the live vaccinia virus. So not good for anyone who's immunocompromised because they can actually get some pretty severe lesions and even pass those on to others. And, when we're dealing with a threat so deadly as smallpox, the risk benefit kind of makes that something that we consider. But when we're talking about smallpox, what we're really talking about is the Jynneos vaccine, because that is not replication competent. It's a 2-dose attenuated live vaccine that's been approved for both smallpox and monkeypox. You may have seen a lot in the news about this vaccine and the scarcity and difficulty getting access to this. We could have a whole other presentation on that, but because of the scarcity, the US has switched from the initially approved subcutaneous route of administration to the intradermal administration, which uses 1/5 of the dose, so really can stretch out the vaccine supply. And there is science behind that. There's a couple good studies that show its effectiveness, but certainly something we're going to learn a lot more about as we get more data from the 2022 outbreak. And so who should get these vaccines? Right now, it's really focusing, the CDC guidelines is focusing in on who's most at risk. So certainly anyone who's been exposed to monkeypox or anyone who's in, these high-risk sexual networks. In terms of exposure, the Jynneos vaccine can be used as post-exposure prophylaxis, meaning it can prevent infection if given within 4 days of exposure, and it can lessen the severity of infection if given within 14 days of exposure. So that's really important to note. Also, please note that on the CDC's list of folks who should be vaccinated are not healthcare workers, because this is not casual spread, and healthcare workers have the PPE needed to protect themselves. And up on the slide here, you see that, to figure out how to access the vaccine, you can contact your local health department. There's also a great website that's not affiliated with the CDC, but the CDC likes it enough to highlight it, the mpoxvaxmap.org. And this will also be included in the resources after this presentation. So next slide. how to talk to your patients about prevention. If they're in a risk category, tell them to get vaccinated. That's really important. Avoid skin-to-skin contact with people who have a rash that looks like monkeypox. Be wary of handling or touching any common bedding, towels, or clothing. And the ever important, wash your hands and use alcohol-based hand sanitizer. You can go on to the next slide. In terms of talking to patients about sex, because this has been associated with sexual transmission, it's important to know that just saying don't have sex has never really worked for anything as a public health strategy. And so we need to think about harm reduction and how we can support our patients having the best sex that they want in the safest way possible. So this could include limiting the number of partners they have temporarily. It could include methods of sex that, virtual sex or phone sex, mutual masturbation that's, at least 6 feet apart. Those are some ways. Condoms, while it's not going to completely prevent monkeypox, could help prevent some of those really painful rectal lesions. Wearing clothes during sex, again, it's not foolproof, but we're talking harm reduction. And then, of course, avoid any kind of contact, kissing, or touching when you're sick. So I wanted to go through a case study that I'll go through rather quickly, but just to kind of give you a sense of I would say like the average case that I've seen. So JW is a 32-year-old man living with HIV who presented to clinic on July 15th for a rash, basically. And so when he presented to clinic, he said that, a couple days previously on July 8th, he noted lesions around his penis. That he thought initially were ingrown hairs, but over the next couple of days, he developed flu-like symptoms, including fever, chills, and body aches that just resolved on their own. And so he's presenting to clinic with concern that the lesions are growing and spreading and becoming itchy. And he does note that he does not have penile discharge, urethritis, rectal pain, rectal discharge, or GI symptoms. And go to the next slide, because we were good at taking our sexual health history. We know that he's had sex with 4 cis men, which just means they're not trans men. They're men assigned male at birth. So he's had 4 partners in the last 2 weeks and didn't always use condoms. And he's had anal sex and oral sex, both as the receptive partner and the penetrative partner. On physical exam, you see about 8, 1 to 2, this is millimeter, sorry, not centimeter, lesions around the base of the penis. It's non-vesicular, but you see that deep embolication. And you also notice bilateral lymphadenopathy that is quite painful. And JW lives in DC, which is a city that had the highest monkeypox rate per capita at one point. So we know epidemiology is not on his side. So then for the poll question, what information that we just discussed supports a monkeypox diagnosis? I'll let you have a second to answer if that's new rash, the fact that he's had 4 male sex partners, the fact that he's had flu-like symptoms, or all of the above. All right, the answer is all of the above. All of those things point to a new case of monkeypox, and here is the CDC case definition, which this patient meets. He had a new characteristic rash. He also had, he met one of the epidemiologic criteria and had a high clinical suspicion for monkeypox. So and this is a classic scenario. You can go on to the next slide. So at this point, I'm concerned about monkeypox. I'm concerned enough to even start the discussion about tecovirimat, but JW is skeptical. He wants to just kind of schedule for follow-up. TPOX requires a whole like 3 to 4 page consent process. He just wants to keep seeing what this is. So we provide information on isolation and making sure he's telling his partners to get vaccinated, and also getting the orthopox swab. And so next slide, we at this point, we got the swab on the 15th, and that swab does in fact come out to be orthopox positive on the 17th. So next slide. So we see him on the 18th, and we know he has monkeypox, and we see the progression of his lesions, and he at this point is interested in starting tecovirimat, and we do indeed start him on tecovirimat. Can go on to the next slide. And this is just an example of a patient diary that's included in the CDC TPOX protocol. And the main takeaways are that he has, by the 3rd day, no more lesions are popping up. He's feeling better. And this patient indeed did not report any side effects to tecovirimat. And by the time we saw him a week later after completing the tecovirimat, all his lesions were healed and we were able to clear him. So I know I'm running short on time, so I'm going to kind of zip through this section. However, I know APIC has some previous webinars on infection prevention and control measures in healthcare settings. But just to highlight, this, you just put the patient in a single person room. It does not need to be an airborne room. There's no special air handling. This monkeypox outbreak is from the clade 2. And so waste management is in the same manner as other potentially infectious waste. There's no special disinfectants that you need to have. It's just the EPA registered hospital grade disinfectants that are generally in clinical settings. You can go on to the next. And so again, the infection prevention measures, this is the kind of standard PPE that we wear: gown, gloves, eye protection, and an N95. So we're all in healthcare very used to wearing this thanks to COVID. So nothing special. And I would even say this is over and above what's probably needed, because there hasn't been an airborne case, but we are just wearing that N95 just to be extra cautious. So I'm just going to close out by briefly acknowledging the stigma. We've talked a lot about the clinical presentation and prevention, but it's important to note that we've been seeing this among gay, bisexual, and other men who have sex with men, and other folks in their sexual networks, including trans and non-binary folks. And so I think it's easy for the media to paint a picture that this is a gay disease, but as scientifically minded people and professionals, we know that there's no such thing as a gay disease. There's no such thing as a virus that knows what your sexuality or gender is. This virus just wants flesh, and it's as simple as that. Anyone can get monkeypox, and any kind of stigmatizing of monkeypox makes things worse. I know we're kind of already starting with some stigma around the name itself, monkeypox. It's not particularly accurate, and it can be dehumanizing. Whitman Walker, and actually the clinic that I work at, and I know a lot of other clinics have been referring to it as MPOX or MPV, MPX, just to avoid that word because it's stigmatizing. But we have indeed seen in the media fear-based messaging and messaging that places blame basically on a population that's already stigmatized in society. We moralize sex, we stigmatize men who have sex with men, and that stigma is just layering and layering on. And as we probably all know, stigma is not healthy emotionally or physically, keeps patients away from care. It keeps health workers from getting the information we need and the tools we need to keep our patients safe. And so I just listed some barriers to care and discrimination that we know play into the current outbreak. I'll just kind of summarize by saying that we don't need to be afraid of monkeypox. We don't need to be afraid of patients with monkeypox. We have the PPE that we need to keep safe. We have the information, and we just need to keep pushing for the appropriate infrastructure and tools that we need. So timely lab testing, getting more vaccine and more treatment available. And my last slide, just a little bit of good news is that, LGBTQ health organizations and leaders have really mobilized to get the information out there and get the advocacy for more vaccine and treatment out there, which has really made a difference in the outbreak. Incidence is going down in most places, and we're starting to get ahead of this. However, it's not over. From what I've read, it's not likely to be completely eradicated in the near future in the US. So we need to continue working for resources to STI clinics and other healthcare centers. And of course, we need to continue to fight stigma and reduce health disparities. I went 5 minutes over. I apologize, but I'll hand it off so that Anna can talk a little bit more about the resource kit that ANA has developed, which will hopefully be helpful.
Thank you so much, Amanda. Wonderful presentation. I'm sure many of you are interested in getting a copy of these slides or having this information available. And we want you to know that ANA and APIC have gone ahead and taken this into consideration. We've developed a monkeypox resource toolkit, which is available online. We actually have the link included here in the chat for you to access it. But basically, it's a summarization of today's presentation. It's based on the clinical national standard guidance, and obviously includes a lot of the information for today. Next slide. So this is just an example of what it looks like. As you can see, it's a summarization of the key clinical information that Amanda just spoke to you about today. There are links embedded for you to access information. As Amanda had stated, this monkeypox information is continually evolving, so it will be important to stay up to date with any changes. Next slide. We also include a lot of the visuals, as we know that, if you go to the CDC website and a lot of these other websites, it can be extremely wordy. So this way you can actually access the information and see it in a visual format. Next slide. We've also included some questions for patient history, as well as things to be taken into consideration when you're examining the patient. We have included, like I said, lots of questions, but we've also included just information on how to basically provide a safe and welcoming environment for all patients, and some of the suggestions on how you can do that. We've also included the links as to how to do a sexual history, if that's something that you're not experienced and need some more guidance. And we've also included questions in relation to patients who you suspect may have monkeypox or may need treatment or vaccination, as you need to consider their medical history. Next slide. And then lastly, as I stated, there's resources, links that we've included. So this is just an example of some. There are others listed. We've also included the APIC and ANA websites for information in relation to infection prevention and control, and just how to apply these in the healthcare environment. So like, for example, the ANA and CDC Project First Line website that offers you further training in relation to these concepts. Next slide. And that is the presentation. Thank you so much. I think we're going to send it back to Barbara.
Thank you, Anna, and thank you, Amanda. That was very, very comprehensive. We have a question from one of our audience members that works in a busy ED, has encountered some male patients who deny having sex with other men for whatever reasons, because of embarrassment or because of their job. So do you have any advice on how to obtain an accurate risk factor or sexual history?
Yeah, and again, this could probably be a whole other presentation. I know
Sure,
Anna has
yeah.
included some links there. I'll say that, you know, for me in the more primary care setting, I have a little bit more time to establish a trusting relationship and a safe space. In the ED, it's hard. I mean, I think, you know, for quick information that's relevant, you can kind of just say like, I don't know, you can talk about how the people who are most impacted and kind of the association with sex, and maybe ask like, have, you know, more non-specifically, like, have you had contact with anyone in this way, or like, you can kind of just soften the way you answer the question. But I think the real a true answer would take a whole presentation. So I would encourage you to look at the resources that Anna put out, because I think as a medical community, we need to do better at that in general.
Agreed, agreed. Well, thank you, Amanda. I think we've all gotten a lot out of your presentation, and the slides look beautiful, I have to say. We can say that as healthcare workers. I don't know that other people would think that. And Molly, I think we're almost at time if you want to send us off.
Sounds good. Thank you, Barbara. So thank you again to Amanda, our partners at ANA, all of our panelists, great work. Thank you so, so much. As a reminder, the webinar is accompanied by 1 credit today. As APIC is in the process of transitioning to a new learning management system that will be launched in the coming days, this webinar will not appear in a dashboard until the transition has been made. Please contact us at elearning@apic.org if you have additional questions. You should be able to access your certificate in the next week or 2. Thank you again for your patience and understanding as we make this very exciting transition. This concludes our program today. Thank you all so much again, and you may now disconnect.